Hi, this is Elliot Fishman, and now let's do part 6, which is the final part. And I've saved some of the best cases for last. So I left off last time asking you about a patient with an acute abdomen for 12 hours. But look how edematous that small bowel is. There's ascites present. Patient was in severe pain. This looked like an acute abdomen. Looked like maybe ischemic or infarcted bowel. When you got more history, the patient had been to the doctor the day before and was put on new blood pressure medicine, the patient thought. Look how extensive the bowel is. Look at the edematous changes. Look at the fold thickening, the mucosal enhancement. Very, very prominent. Not exactly a pan small bowel involvement, but extensive involvement, a little bit of ascites, and rapid onset. So what are you thinking? Well, when you have rapid onset, you got to think about infection. We spoke about in the last talk salmonella, and we spoke about MAI. But what about drug-induced problems? And I told you the patient went to their cardiologist. Well, this is a classic example of ACE inhibitor angioedema. That's why the bowel is so edematous. It's not ischemia, it's angioedema. It's a clinical manifestation of inflammation-mediated edema in the dermis or subcutaneous tissues owing to increased permeability across capillaries. It may involve the skin and respiratory and GI tract, and generally resolves after 24 hours of discontinuing the medicine. Patients who are very sensitive can take one dose of the medicine and get this severe angioedema, indeed which this patient had. Again, very impressive CT scan. Another example, acute abdomen. Look at the patient's duodenum and jejunum. There's also ascites present. Look how extensive the involvement is proximally, but the distal bowel is not involved. I don't see any adhesions. It's all edematous changes. The more you look at the bowel, you realize, yes, there is ascites, and yes, there is edema, but the bowel is markedly edematous. You have poor enhancement, and again, you are worrying about ischemia. Look at the stretching of the vessels. Could this be ischemic bowel? I would be looking at the mesenteric vessels, but they were not occluded, so it's not like acute infarction of bowel. But it really is, in this case, compared to the other case, really extensive small bowel involvement. But the vessels are small but patent, and you have all of this edematous changes. And I'm showing you a range of the images we had from this patient. And this was also a case of ACE inhibitor with small bowel edema. What a wonderful case. Now let me show you a case I come across recently. Patients with scleroderma, we know from plain films, have dilated small bowel. It doesn't mean they have obstruction. But this patient had abdominal pain, and look at the dilated small bowel. And then you look at the transition. Where's the change? Because distally the bowel's okay. There's a loop over here that's thickened. You can see it right there. Now I'm going to show it to you with a few different images. There it is there. Thickened bowel, very focally thickened, mid-small bowel causing what looks like proximal obstruction. And it goes for about 7 or 8 centimeters. And if you look at the haustral folds are very, very prominent in this region, and compare that to the folds elsewhere in the bowel, but all that proximal dilatation, here it is from a sagittal view, really impressive. And I told you the patient has scleroderma. Scleroderma, focally thickened bowel, looks like it's causing obstruction, prominent vasa recta very close together. That's called hidebound bowel. First reported a long time ago, more than 50 years ago. And it talks about, and classic for scleroderma, the closely spaced valvulae coniventes, sometimes referred to as increased number of folds per inch, can be readily identified on CT or MR. And this is classic for scleroderma. Small bowel is the second most common site of GI scleroderma after the esophagus. We think about the esophagus more with scleroderma, right? Particularly the GE junction, but it also involves the small bowel. We commonly see dilated small bowel without obstruction in scleroderma, But here's an example of where there's focal thickening and a transition, and this was scleroderma. And this is from the original article showing you how similar it is to the case we are showing you today. Now, another case, suspected small bowel obstruction. Look at the dilated loops of bowel. So we're thinking dilated bowel, there is submucosal enhancement and thickening. Could this be Crohn's disease? Could this be potentially angioedema of bowel? What are we dealing with? And we're following it down. It's going to the terminal ileum. And it's really impressive. Markedly dilated bowel, edematous changes. There's some free fluid in the right lower quadrant. And it looks like the transition is near the terminal ileum. And we're looking at it closer. Now, I showed you some infection, and you could say, well, maybe I'm holding something back. The infection that occurs in the terminal ileum by the ileocecal valve classically is tuberculosis. You have a stricture, and it causes bowel obstruction. And that's a thought, but this was not TB. You see the vessels here, so I'm trying to figure out what's going on. Why is the bowel so dilated? And the transition, could it be a stricture? I don't see anything to suggest Crohn's. I don't see a tumor. And if you look at this more carefully, and again, it's hard to follow, but you see the dilated loops of bowel, and then you see the inflammation in the right lower quadrant and some free fluid present. And then you look at it on the coronal view as well, and you say, okay, I know there's something going on. There's bowel obstruction, and I know it's really distally. And then you look and you say, what's happening about right there? Let me go back. What's happening right there? It's near the vessels. The vessels all look good. There's something mass-like right here. Well, as you look more carefully at that, and we go beyond these images, there was actually a small mass that was hard to see that was a Meckel's diverticulum, and that Meckel's diverticulum was causing the bowel obstruction. And here it is right here. When you look at it quickly, it looks like just a loop of bowel, but it was really outside of the bowel and next to the bowel. Almost looks like a big appendix. But this was a Meckel's diverticulum causing inflammation and distal obstruction. So when we talk about bowel obstruction, we talk about tumors. In the tumor category, we should probably put something that's sort of like a tumor, which is Meckel's diverticulum. We think about Meckel's as GI bleeding, particularly in the PEDS patients, but it also can cause obstruction. You can get diverticulitis from Meckel's, and it may be difficult to distinguish from processes like appendicitis, IBD, or other causes of small bowel obstruction. And in this case, we knew there was distal bowel obstruction. The patient went to surgery. We thought it might be adhesions because we didn't see a mass, but at the end, it was a Meckel's diverticulum, which can be really, really challenging. Satomi Kawamoto wrote an article about that. I always reread the article. I look at cases because Meckel's is rare. It has many different appearances, but it's often a difficult diagnosis. So when I think about distal bowel obstruction, but I can't find a cause, I'm going to say, well, could this patient have Meckel's? And then I'll look a lot more carefully to make sure. Again, Meckel's can cause obstruction by adhesions, by intussusception, by volvulus or internal hernia. So Meckel's has a range of appearances and can simulate many, many other things. So again, it's really a difficult diagnosis. Now, speaking about difficult diagnosis, here's a case I saw with abdominal pain, bowel obstruction, mesenteric nodes, which are enhancing, and then there's distally thickened small bowel with enhancement, but looks mass-like. So I'm thinking there's a mass in the distal small bowel. Maybe this is lymphoma because it's bulky, and particularly because the patient had significant adenopathy. There's the mass-like process of thickening of bowel, infiltration of bowel. There's the multiple nodes we saw and see again right here and see here. So I'm asking you, what am I dealing with? Is this a simple case of nodes, thickened bowel, is this lymphoma, maybe adenocarcinoma, but this surely has to be malignancy. Well, this wasn't malignancy. What else could this be? This is not Crohn's disease. This is not an intussusception. This is not Meckel's. Meckel's wouldn't give you those enhancing nodes. So what are you dealing with? Well, this is an amazing case, and I had to read about 4 articles to learn a lot more about that. Remember I showed you previously in the pancreas autoimmune pancreatitis, and remember I showed you when we looked at the kidney at the cortical medullary differentiation, I showed you patchy enhancement of the kidney with autoimmune involvement, IG4 involvement of the kidneys. Well, this is IG4 involvement of the mesentery and the small bowel. And when you read the articles, there's a lot of articles now talking about IG4-related small bowel disease. And to be exact, IgG4-related is a chronic inflammatory condition with tissue infiltration. And you can see it in the GI tract, and you can see that it's a great mimic. It overlaps with other possibilities from Crohn's to lymphoma, and a very, very difficult diagnosis to make. Intestinal involvement in IgG4-related disease can resemble Crohn's. It can resemble malignancy, can resemble other inflammatory etiologies. And I think IgG4 disease is becoming more common these days. And so it's something you need to consider. Consider it in the pancreas, consider it in the liver, consider it in the retroperitoneum if you have what looks like retroperitoneal fibrosis. And now when you have nodes and involvement of bowel, and it's not your typical carcinoid, and it's not your typical lymphoma, think about this possibility as well. And so it's really a challenge, and we're learning a lot more about IgG4 disease, and it's something I think that we need to learn a lot more about. And this is a picture from one of the articles showing IG4-related diseases of the GI tract. Again, beginning the length, esophagus, pancreas, in the oral cavity, the intestines, the retroperitoneum, plus the extra GI zones, whether it's musculoskeletal, whether it's head and neck, or whether it's ocular. Just a very, very impressive disease. Now, a few other things to mention. Anatomy could be one of the causes of small bowel obstruction, particularly when you have the stomach distended and proximal duodenum, and there's encasement, or there appears to be the equivalent of encasement where the SMA and the duodenum will cross. You have that narrowed angle, and it's SMA syndrome. It was initially described in patients with total body casting. We see it in patients with anorexia nervosa. We see it in patients more commonly with marked weight loss. Some older patients have a narrowed SMA angle, but they have no symptoms. Typically, the SMA angle to the aorta is 45 degrees. With SMA syndrome, it's typically less than 10 degrees, and the distance from SMA to aorta is in the 5 millimeter range. Typically what you see, now again, if I just see narrowing of the SMA angle, I'm not going to call SMA syndrome. But here's a good example, a patient with nausea and vomiting and what was thought to be gastric outlet obstruction, big distended stomach, markedly distended duodenum, which you follow across, and you can see the duodenum is narrowed as it goes right between the SMA and the aorta. Here it is on the coronal view, a classic example of SMA syndrome. Just a really nice example. And look at the angle or lack of angle between the SMA and the aorta and the narrow distance. The other thing that gets compressed is the left renal vein. So-called nutcracker syndrome can lead to hypertension. So only 2 things go between the SMA and the aorta. One is the duodenum, third portion, and one is the left renal vein. Another example here, dilated duodenum, rapid transition as it comes across the midline due to SMA obstruction, SMA syndrome. Again, nicely showing you that transition point. When you do patients with suspected SMA syndrome, again, the importance of giving oral contrast, make sure the stomach and duodenum are distended. We say that for all patients, but especially if you're thinking about SMA syndrome, that can be especially helpful in making the diagnosis. Again, that SMA angle nicely shown on the sagittal view is markedly decreased. Another example, they all look the same, right? Dilated duodenum, there's a transition by the SMA, that's the SMV, but SMA, it's narrowed there. And this was SMA syndrome with duodenal obstruction. Again, we talk about malrotations and certain types of problems potentially with malrotations, which can lead to midgut volvulus. So that's also something worth thinking about. But in terms of small bowel obstruction, I always put SMA as a separate entity. Again, another nice example, duodenum dilated. There's the SMA. That's the transition point. Really nicely shown. Okay? There's a couple other good examples. And again, as I make the point, if you only see narrowing of the angle, but you don't see dilatation of the duodenum, that is not SMA syndrome. It's simply narrowed angle. I'll mention it, but I'll say that this is not SMA syndrome because the duodenum is not dilated. And that's a very, very important point. And again, if you notice, I've just showed you 5 cases, and all the cases looked very similar to each other. Okay? Really simple. Now, one thing that always comes up, and I at least give a couple slides in almost every talk these days, I've given you a lot of possibilities of small bowel obstruction. Can we use AI to be more specific? Can AI be used to look at the clinical history, the physical exam, and the imaging studies and be specific to what's going on? There was this machine learning-based prediction model for closed-loop bowel obstruction. This article was published a couple years ago, and there have been several other articles. They, were able to use, as always something AI seems to add. Prior surgery, age, lactate, World sign, UC shape, bowel configuration, and fecalization were the most important variables in predicting closed-loop small bowel obstruction. But you don't need a computer program to tell you that. So until the computer gets a lot better and predicts the obstruction before it occurs, I think we still have a job. In conclusion, when applied to CTs obtained to assess suspected bowel obstruction, a model combining supervised 2D and 3D convolutional neural networks effectively identified those CTs showing evidence of bowel obstruction. Again, I just want to bring up the point that people are looking at this area like they're looking at everything. We personally are looking closely at pancreatic cancer detection. This is kind of a little different, but I think at this point the radiologists can do better than AI as long as they follow the rules we discussed and think about the various examples. And again, this article suggests that perhaps it could be helpful, particularly for radiologists with less experience. AI can aid urgent CT readings. 3D mixed convolutional network, CNNs, automates CT reading prioritization effectively and speeds up bowel obstruction diagnosis. So one of their points is perhaps if AI can look at the cases first, and if you have a busy list or you can't get through cases today, it would say, oh, I'm worried about bowel obstruction, I'm worried about complications, and move it to the front of the list. I think for triaging cases, AI may indeed be ideal. So concluding then, we've looked at a range of small bowel obstructions. We looked at how we do the studies, how we interpret the studies, some of the classic findings, some of the challenges. And I hope that looking at all of these cases will give you a better understanding of how we need to look at small bowel obstruction and how we can be of use to our patients and our referring clinicians. And with that, have a great day. And oh yes, thanks for paying attention. See you later. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.